It's my pleasure to introduce now Dr. Marlies Ostermann. She's coming up, I see, yes. Marlies Ostermann will enlighten us on lactate in critical illness.
Thank you very much. Thank you to Ravi and the organizers for inviting me and to contribute to this important session. So in the next 15 minutes, I will talk to you about lactate, and I hope I can convince you that it's an important component with a very important role. I have no particular conflicts related to this talk. So here's a slide, which is now more than 60 years old, and it will display what you probably all feel, and what you know. Lactate is a marker of badness, and as shown here, people with a high lactate have a higher risk of dying, and there's a correlation. And very often, and certainly in the practice where I work, clearly lactate is something bad, and people want to react, and sadly, often the response is to give a bit of extra fluid and a bit of extra something to make things better. But fluid seems to be a very automatic response. And I want to put it to you and hopefully convince you in the next 10 minutes that that may not always be the right thing to do, and second, that lactate actually has a role, a physiologic role. So we all produce lactate. It's a normal product of glycolysis. Now, if you remember your normal physiology and biochemistry, then you obviously know that ATP is produced in the mitochondria via oxidative phosphorylation through the Krebs cycle or TCA cycle. Now, the Krebs cycle is oxygen dependent, and in situations where we don't have enough oxygen or in situations of hypoxia, the Krebs cycle is inhibited. Now, the cells respond and then activate glycolysis to compensate for the lack of ATP. And then, as I've already said, and as shown here, this will then lead to the generation of lactate. Again, nature prepared us and put various processes in place to deal with the lactate as it now potentially builds up in this rescue operation. Number one, lactate can be metabolized to pyruvate again and then be introduced into the Krebs cycle. For this process, an enzyme called pyruvate dehydrogenase is very important. But we can make use of our lactate and essentially introduce it into the Krebs cycle to make ATP again. We can also use lactate to allow it to enter the nucleus and to activate the expression of various genes. And I'll get back to that in a few minutes. And lastly, lactate can be used to metabolized and can be used to produce glucose again. So it's part of gluconeogenesis. And what I've shown here is what happens in the cells, but we also make lactate outside the cells, and we have mechanisms in place to slot lactate from extracellular into the cytoplasm to make use of these processes. So there's a close relationship between lactate and glucose. And most cells need glucose to produce ATP in the mitochondria by the Krebs cycle. And there are systems in place to help cells in situations where there's not enough glucose or where they need extra energy, and then they just slot extra glucose into the cells and activate glycolysis, obviously at the expense of making more lactate. But then we have systems in place to mop up the lactate very quickly and, in fact, to generate extra energy through the Krebs cycle and to facilitate gluconeogenesis. So actually, lactate is a valuable substance, a substrate to generate energy and to generate glucose. It's particularly important in stress situations. And I've already alluded to the fact that lactate has various roles. It has a role in generating ATP via the Krebs cycle in the mitochondria. It activates gene expression in the nucleus, and it can also help other physiological processes. It can help various cells and physiological processes, in particular cardiac function, muscle function, and plays a role in the regulation of various immune processes. And I've already alluded to the fact that glycolysis can be activated. It's a rescue operation. It can be activated by various situations where the cell is under stress, needs extra energy, or because the cells are particularly active, muscle cells, for instance, or it's a rescue process in situations where the cells are at risk, hypoxia, for instance. And then we have processes in place to eliminate, to mop up the extra lactate. So there's a continuous relationship usually between production and elimination. And we will only see changes in the blood concentration if the balance is out of control. The usual response is to eliminate more and metabolize more lactate if more is produced. Now, obviously in critical care at the bedside, we may see patients with raised lactate and we get alarmed. And most of the time, we think it is related to the fact that the cells are under stress and may be hypoxic and may be starving. But there may be a situation of reduced oxygen delivery or reduced perfusion. Now, again, the body or physiology prepared us for these situations. So in situations of reduced oxygen delivery or reduced perfusions, we physiologically reduce our oxygen consumption. And by doing that for a while, we can keep our lactate concentrations in the normal range, in the stable range. Now, obviously, this can happen only up to a critical moment. And if oxygen delivery or perfusion then continues to deteriorate, oxygen consumption cannot go down any further, and the lactate will go up. And this is obviously a common scenario, and that's what prompts a lot of people to intervene and to initiate rescue procedures, fluids, inotropes. But I want to remind you again that a normal plasma lactate does not necessarily mean that perfusion and oxygen delivery are adequate. As you can see, we have a bit of room to play with up to a certain point. So a normal lactate doesn't rule out a problem. At the same time, a raised lactate doesn't mean perfusion is impaired or oxygen delivery isn't adequate, because there's so many situations where the lactate may go up due to other reasons. For instance, there may be increased glycolysis due to increased muscle activity, or due to rapidly dividing cells, or due to an acute crisis as an asthma attack, and then even worsened by us giving bronchodilators. There may be a situation where the production isn't necessarily increased, but elimination is a problem, because the liver may have deteriorated in the context of sepsis, for instance. There may be a situation where patients are taking medications, retroviral medications, metformin, that interfere with all these processes, and again, reduce the ability to eliminate. And then there may be some rarer conditions as listed here, all leading to a raised lactate concentration in the plasma. So when we see patients with a raised lactate, as I've already said, we often associate this with badness, and we, certainly where I work, have this knee-jerk response to focus on perfusion and oxygen delivery. Now, we do this because we know from experience, but also from the literature, that it's a good thing if the lactate can come down again. And we've experienced this, but it's also supported in the literature by a systematic review here by Jean-Louis Vincent, where he looked at the existing data, evaluating the lactate kinetics and changes in lactate in response to therapeutic interventions. Looking at the data of 96 studies with all different degrees of shock, they clearly showed this relationship. So patients whose serially lactate levels came down, here in green, had a better outcome, and patients with a rising lactate, here in red, had a worse outcome. So a decrease in lactate is associated with better outcomes, and importantly, the relationship between the kinetics and outcomes holds true regardless of the baseline value. So lactate coming down is a good thing. I do accept that the majority of people in critical illness may have a raised lactate because of perfusion problems or oxygen delivery problem. And I fully accept that patients with a raised lactate have a worse prognosis and are at risk of poor outcomes. But at the same time, a patient with a raised lactate who looks clinically well and is adequately perfused does not need these fluid or inotrope resuscitation maneuvers. And in fact, I put it to you, they may well come to harm if you add inotropes when they're not needed, or you add fluids when they're not needed. And I would urge everybody, and that's certainly what at the bedside, that we remember the differential diagnosis of hyperlactatemia. I accept that hypoperfusion and reduced oxygen delivery are probably at the top in the majority of patients, but there are so many other conditions which I listed that may contribute, and they do not need fluid and they don't need inotropes. And therefore, a raised lactate, it needs to be interpreted within the clinical context. So I hope I've convinced you that lactate isn't just bad. It's a biomarker of badness, which I accept, but it's also a very useful regulator of essential processes. It serves energy and fuel production. It is a biomarker which gives us information about risk of poor outcomes, and it needs to be interpreted at the bedside using in light of the clinical context. Thank you for your attention.
We have time for a question if anybody would like to ask Professor Ostermann a question. Okay, Marlies, I'll ask you a question. Yeah. You've given us a great overview of sort of lactate and a little bit of, people will make fun of me, but the mom and apple pie, right? Depends on the clinical context, right? Interpret sort of in the context. Practically speaking, when you're at the bedside, right, and you have a patient who comes in with undifferentiated shock and hyperlactin, what do you do sort of in the short term? Do you measure a second lactate quickly thereafter? Do you give fluid and see what happens to the lactate? How do you think about that clinical context?
So first of all, I see whether there's a lactate from before. So as the trends are important. And then secondly, I examine the patient. And if the patient is adequately perfused using clinical skills and potentially an ultrasound, then I would stop people giving extra fluid and inotropes. And I look at the drug chart and see whether there's an explanation. But it's the trends. And if I'm not sure, but the patient doesn't need further resuscitation, then I'll see what the next one does an hour or 2 hours later. And lactate responds quickly. I should have said this. In the systematic review, changes within 1 to 2 hours were predictive.
Great. And anyone else with a question for Professor Ostermann? Great. Thank you so much for a really informative talk.